Andrew was 8 months old when a section of his bowel was removed and connected to the esophagus. This gives the advantage of using his own tissue, which is mobile and grows with him.
Some of the facts revealed in the film so far are clearly likely to disturb a new TOF parent, whom I suspect had never heard of the condition before becoming directly involved with it. Can you offer any comfort to parents who are still in the early stages of TOF?
Yes, and the majority of children with esophageal atresia and tracheoesophageal fistula do end up as normal adults. There are a lot of early problems, but nearly all of these can be solved surgically. Not everybody gets better because there are associated problems.
So we can say the success rate is encouraging?
Yes, very. For many units, it is years since a baby died of esophageal atresia or tracheoesophageal fistula and its direct complications. What the babies do die of, and this is quite a small percentage, are the associated other lesions, particularly kidney problems and heart problems.
Is permanent disability a possible result of TOF or OA?
Unfortunately, I have to say yes. There can be long-term problems in getting the gullet joined up, and with these there may be difficulty with swallowing, there may be permanent difficulty with swallowing, and some children have long-term difficulties with breathing. But it is important to remember that these are very uncommon nowadays.
Many TOF children have an instantly recognisable metallic barking cough, which echoes in the chest.
You might get more now she's eating a biscuit.
It is known as the TOF cough and is due to tracheomalacia. The windpipe is narrower and softer than normal, so producing this distressing sound. The joint in the gullet may narrow, causing a stricture which will lead to food sticking. This narrowing can be dilated by the surgeon. When food does stick, most children are able to immediately regurgitate it. Others may store it, causing a build-up, making the esophagus bulge and press on the windpipe. This causes the air supply to be cut off and places the child in danger. An immediate response is necessary.
It appears that the majority of TOF and OA babies have feeding problems when they grow. Are parents forewarned of these problems, and do they receive the support of dietitians regarding a balanced diet?
Perhaps surgeons have been a little remiss so far of warning parents of what they might expect after the initial operation is over. This is because we have been so concerned with survival. However, now that we have achieved very good results where survival is concerned, therefore we are not so concerned about the mortality, we are now paying attention to the morbidity. It is still very difficult to say which child is going to have swallowing troubles and who is not going to have swallowing troubles. However, there are some children who do develop stricture, and therefore we know that these are the children who are going to have problems. And we are now starting to advise parents on how to give these children more liquidized diets to begin with, and when they're older to make sure that they chew the food well, or perhaps cut up the food in smaller pieces. But as I said, we cannot tell beforehand which child is going to develop the problems, and therefore we have to go along as the follow-up continues. A dietitian is necessary because she may be able to advise in getting adequate amounts of nutrition into these patients. However, most of these children are able to absorb the food once, of course, it enters the stomach. So they shouldn't have problems with malabsorption. It is just a matter of stricture. It's a mechanical problem.
What are the advantages or disadvantages of entering the chest either vertically under the arm or horizontally across the chest?
There are no advantages or disadvantages as such. The standard approach to enter the chest, i.e. to do a thoracotomy, is through a horizontal approach. However, in the late 40s, the late Sir Dennis Brown, a surgeon at Great Ormond Street, found that entering the chest vertically gave a better cosmetic result, and therefore he started this, and a lot of surgeons have followed it, but not everyone opts to do that. The advantages are the same for both, i.e. that you get a very good view of the esophagus and of the fistula, therefore you can choose any. But once again, it depends on the surgeon's choice. Some prefer to do a horizontal and others prefer to do a vertical, merely because the advantage of a vertical is that when the child has the arm by the side, you can't see the scar at all.
Surgery for TOF became successful in the 1940s. The oldest surviving patients are approaching middle age.
I was immediately transferred to Great Ormond Street under the care of Mr. David Waterson. He warned my parents that the operation was touch and go, but added that I had a strong heart, and though they had just pioneered this type of operation, they had had one success before.
David Bland, a younger adult TOF, lets nothing stop him from enjoying life.
When I was 16, I applied to join the police force, passed the medical to get in, which is fairly strict medical. They accepted me. Not that I'm in the police force anymore, but there you go. Also, I do a hell of a lot of whitewater canoeing, rock climbing, this sort of thing. Very fit, active life. It's, as far as I'm concerned, I'm totally normal. And I'd just like to finish on one fairly big point. At no time in my life have I ever had to think, I can't do something I want to do because I've had this condition. I think that's the important thing.
Parents worry considerably in the early years of their child's life. They can feel dreadfully isolated.
It has been indicated that GPs know little, if anything, about TOF and OA. This must accentuate the desolation felt by new TOF parents. Do you believe that more GPs are now becoming acquainted with the condition?
This condition is not a very common condition, and therefore even the ordinary hospital doctors do not come across it all that often. However, more and more is now being known about this condition, and certainly the average textbooks of pediatrics, which every medical student now learns, has the mention of esophageal atresia and tracheoesophageal fistula, and also the general practitioner training scheme now incorporates part of their training in hospital on the pediatric wards, and therefore they're becoming more familiar with this condition. And of course, our communication with them is improving, discharge summaries, personal communications, and with the health visitors who now visit hospitals and homes, I certainly hope that better communications are being established.
The TOFS group was formed in 1982 when two mothers, Linda Morris from Chesterfield and Julia Grimm from Wales, both wrote to the Voluntary Council for Handicapped Children at the same time. They were introduced to each other and were relieved to learn they were not alone in their dilemma. A letter to Health Visitor magazine brought together 15 more families. Further expansion led to the formation of TOFS, which for the first 7 years of its existence was run by Linda from her home.
Put your name in the envelope with your information. Right. Yes, it really is absolutely fine. I'm sure that she's going to do very well.
TOFS now has several hundred families nationwide and is in touch with similar parents' organisations abroad.
This map shows the distribution of our membership. The white ones represent ordinary members, and the orange ones show the members who are actually working for the group, the local coordinators, etc. And our aim is to establish a local branch in every area of the country.